So I wanted to thank everybody along with, on Al's behalf, for this invitation. It's a beautiful city and country, and we sort of were invited because we do things slightly different, both in lesion set and in sequencing. Take it, that goes forward. Oh, the big green button. There we go. Oh, so disclosures, there we go. So this would be equivalent of my iceberg slide from yesterday, and it sort of makes me laugh because if you believe this dating back to 2000 BC, we're not the only mankind to be dealing with AFib. They've been dealing it for years. This is from the Yellow Emperor's internal medicine book, but more likely probably in the 1680s, AFib was discovered in oracles, but we're not the first. So we began this approach because we were receiving a lot of patients, both with AFib and complex atrial arrhythmias, and a lot of them were redo prior AFib ablations. And a lot of these cases, I was bringing them to the electrophysiology laboratory and mapping them and having difficulty at times getting to certain anatomic locations. Sometimes I was restricted by phrenic, esophageal temperatures. And I was trying to figure out a way best to both treat these atrial arrhythmias, map them accurately, then bring them up possibly to the surgical OR to perform the epicardial approach. And at first thinking about this, it made complete sense, at least to the three of us, Dr. DeMeo and Dr. Squarteri, the surgeons, that why not take advantage of what we do well as electrophysiologists, which is map and ablate, essentially find the arrhythmia, right? And surgeons rely on their anatomic knowledge, and it's an anatomic ablation at times for them. And I feel like it optimizes things with us going first and them going second. Particularly, I was concerned with edema set-in from the epicardial approach, and then with acute mapping in that setting. At times, I was worried that that may interfere with endocardial mapping. So we set off with a small subset of patients to try to figure this out. Vice versa, there you go. So along that way, there was a couple years of trying things differently. So we did try the epicardial first, and then we sequenced out when I came in up to 90 days, 120 days, so forth. We also performed the convergent, the pericardioscopic approach in our hospital, and then we sort of fell in last to this epicardial. The laser is the light, there we go. So then we tried our approach. So right now we perform, and I'm going to get more into this. I'm going to show two case presentations quickly, and then we'll show in literature our thinking behind this, how it developed. But right now we're doing it within 24 hours. Currently we're set up to do same day, but still preserve the endo then epi approach. So this all evolved, and the nidus for this was this one particular patient. This represented a lot of our patients. He was a young gentleman. At first, when he was diagnosed with AFib, they originally treated him with antiarrhythmics and aviodinal agents. He dealt with that for about 5 years, but like any healthy 30-year-old gentleman who was active, he didn't want to be on meds. He didn't want to be dealing with this. He didn't want to be going to the ER for cardioversion. So he went to an outside institution, and they performed a simple WACA at that time. He had early recurrence. They put him back on antiarrhythmics, which he despised. Discontinued it, and then he suffered a second recurrence. He said, I had enough. He went back within a year to the same institution. This time they performed a re-isolation of the lefts, roof, mitral, and a cable tricuspid line. He recurred again, and this time he said, I'm done with antiarrhythmics, I'm done with the EP insert, the world of EP, I'm angry. So he sort of did okay though. He maintained for about 4 or 5 years, on and off episodes that cardioverted, and he was okay with that off medications. And then he came back, and he became, this time he began to exhibit various atrial arrhythmias and his AFib. He went back a third time, and this time they re-isolated all veins per their op note, and they ablated a mitral flutter line. He recurred within 24 hours, they cardioverted him, 48 hours cardioverted him, and then he just kept continuing, became a persistent state. And then that's when he fell into my lap at this point. So this is, so this was his atrial arrhythmia, and this was his AFib. It doesn't show up very well, but it's positive inferiorly, negative in one, but I tend not to put much credence in this because once the left atrium's been debulked with a pen, with ablations, it's just that your surface vectors are thrown off. So take it for what that is. This is what it looked like. I'm limited on some of the electrograms I have, but there's evidence here of the prior cavo tricuspid line with this block. But it was about 220 230 in the lab, very stable. We brought him then, I forget what my next slide is. So we brought him then to the EP lab. And what we do is we ablate, but prior to ablation, we have to map. And this was the advantage of this, where I first studied the right atrium, and I only mapped about 120, 130 milliseconds. Is that me or is that you doing that? Of the cycle length. Nope. And so I wasn't the right atrium. Then we went to the left atrium, and there we got approximately 200, almost 90, 95% of the cycle length. And just to jump forward, so that's doing it on its own. There we go. So to just jump forward, we mapped it to here. I ablated, and you saw in the next slide, it slowed to about 320, so much greater than almost 50% of its cycle length. So generally, that's a nice finding you like to see, but couldn't get it to terminate. Then I checked the veins, and only the right lower was actually isolated. So at that time, we made a decision to do wide areas. You know, these were the original, about 4 or 5 around here. I continued the roof. I drew the esophagus in here because we had a horrendous time with this guy, with both increase in temperature, the rapid rate, and the absolute number was going extremely high, so it sort of limited a lot of my posterior ablations. These were some cafes I mapped just anterior and to the os of the appendage, and this sort of became the lesion set that then I adopted for further lesion sets that we then standardized for our study here, which I'll show you. He also subsequently septally had some areas that we ablated. So what happened was the following day, Dr. DeMayo brought him up to the OR, and while he was dissecting in that area, so had not even begun ablating it, was dissecting termination of the arrhythmia. So at that point, we were sort of thinking, you know, we're on to something, because we know manipulation of the heart can also terminate. We know that there's bump ablations for bypass tracks if you're actually endocardially, but even epicardially with manipulation, you can get this, and it was exactly in this zone. And we've had further patients with this, which for the sake of time I can't show you, but this was the slowing. I don't know why it's jumping like that. This was the esophagus. This makes sense on this CAT scan. And this was a bugger to ablate around. And then that was the other advantage of this, was I didn't actually have to perseverate in that area. You know, sometimes we get a little dangerous with our ablations in the esophagus. We push the limit at times because you can only change your wide area so many times and alter your line without, I believe that contributes to a lot of these gaps forming. So a lot of this, when I went up and talked to Al, I said, listen, this is a patient that not only I think you should go to this area where I saw his atrial arrhythmia, we should re-isolate, but also help me anatomically, because posteriorly I'm not really convinced at all that these lines and ablation sets are going to be transmural. I think, so this was the thing. We've all seen this slide, right? We know the complexity of the ganglia. We know rotors, drivers. We know there's pulmonic, extrapulmonic triggers. Putting it all together, it's a very chaotic scene. But we also believe in this, that we also have to treat other atrial arrhythmias. These patients have other arrhythmias, whether they're clinically relevant on presentation or they're just, we know from the literature they're prone to these other arrhythmias when you follow them further out. So that was like step one to what we wanted to do. So these are the, you know, putting it on a slide, we have the triggers, modulating, sustainers, and substrate. And each one of these takes on a different role and weight as you progress from paroxysmal persistent and long-standing persistent. We know that. But, you know, I venture to add this on as a side loop to that. Furthermore, this was from an outside hospital. I wish I could break in and download the EP study, but all I have is the EKG that I stole when you know, I keep these interesting EKGs with me. And this was another gentleman who only had 2 prior, which is great in our area, isolations. First, he had just a circumferential wide area for paroxysmal AFib. Then he went back with a recurrence, had a second re-isolation of his veins with a right-sided line. He then came back in this rhythm. And this is negative here, positive here, and it sort of transitions here. And maybe in L, it's maybe initial positive and then a downward deflection. Once again, take it for what that means, but you know, we were maybe thinking possibly left or a septal location, but what happened was when we did the electroanatomic map, right side didn't get it, we went to the left. Earliest activation was actually in the mitral annulus, so with initial ablations there we got a little slowing, no termination. And then went back and looked at the septum, we thought we had some early points, then went into the coronary sinus, and lo and behold, you could see these potentials before each of the flutter waves. And an ablation about centimeter into the CS os had termination. And it's really interesting, and this is in the literature, you can see this, but you could then see the potentials completely dissociated, running at the rate of the tachycardia with the patient in sinus rhythm. So at that point, we said, well, maybe are we missing these muscular sleeves that are connecting the ligament of Marshall, through the CS to the right atrium, these interatrial communications. Do these also have to be addressed? And that's why we sort of now throw that on, along with the appendage, along with the ligament of Marshall, along with the CS, and I'll tell you how we do that in our study. Just quickly going through these studies. So this was just 10 hearts, and they went through and they showed its variability, but all these hearts, these are autopsied human hearts now, they all had a consistent muscular sleeve here, as you can see running here. And all the way up to the Thebesian valve, and Vucen's is here. So this was a fairly consistent pattern that connected all the way up to the ligament of Marshall and down, and sometimes to the posterior left free wall. So there's clear, it's not just Bachman's bundle at times that we deal with. Now, whether this contributes, clearly doesn't contribute a majority of the time, but if this adds 5–10% to these cases, I think in additive effect, it's going to help us. And so with that, it must be on an auto advance, I'm not sure why. Following this up, the ligament of Marshall study here, this study has showed us that the ligament of Marshall, as we know, is a complex, as everybody knows, a neurovascular bundle. It's heavily innervated, and there's various striated muscle connections. And they nicely showed here in these longitudinal histo that here's the adipose, left, and ligament of Marshall. You can see these three bands slowly come across. They insert into the free wall of the left atrium, and they also insert down into the CS. So this sort of just anatomically, you can see this framework, and you could argue that multiple branches point almost sets up for a reentry in arrhythmia within that. Possibly, I don't know if I have this on the timing. Oh, they're not paying attention, but maybe we could take it off the auto timing. If you could pause it possibly. But so to support that, we had 4 terminations out of our 50 that we've done up to about last year with the clip. When we place a clip. And I'll show you, that's the last thing we do. That's the last action of our procedure. So patients in AFib the entire time, the last bit of action that we do is lay that clip down, and we had termination of 4. And that's supported in the registry with the Lariat device. There's been clear terminations of their AFib with no ablations with the Lariat placement. So, the appendage to me is both a thromboembolic, it needs to be addressed thromboembolic, and needs to be addressed along electrophysiologic issues. And I think it carries weight on both sides. So I sort of stopped myself from weighing in whether the appendage should be taken in the prior discussions, but I believe it does, and for both points moving forward. This was interesting. So this was histo again, and they had 7 autopsied hearts. So these patients all had open heart surgery, concomitant ablation with an open irrigated catheter in unipolar fashion. And they essentially wanted to see wall thickness. They got an average of approximately 5 millimeters of thickness. The hardest for them to ablate, as predicted, was the mitral annulus. And only 1 of 7 had transmurality. And then the right atrium here along the cava tricuspid was the other difficult area of wall thickness up to 10, which we know about. So that sort of says to us, well, mitral valve, stay away from it, high rate of atrial arrhythmia recurrences, leading to a lot of post-failures under that 30 seconds or more of an atrial arrhythmia endpoint that we lead for ourselves. So we opted to take that out. Someone mentioned the Utah group. Yesterday, I'm taking it to their edema study, where this is another argument of mine that, this is extrapolation a bit because this was endovascular ablation, but they got these patients after an ablation, they did an MRI before, immediately post, and then 30 months after. And you can tell acutely, as soon as I brought them in, they both non-enhancing and hyper-enhancing lesions. About 72% of initial post-ablation had injury diffusely throughout the left atrium. Of that, only 33.9% was scar. But what this tells me is initially, when you're ablating these people, you're getting a lot of edema, and more than you think. It's just not where you're placing it, but you're getting edema throughout this that we clearly see. And it's just this transient inflammation and edema. But I think if you're doing it in the same setting, it has the possible effect of endovascularly affecting your mapping. Once again, I mentioned this. This is by Parikh and his colleagues. They left atrial size. At 117 and above, it was a significant predictor of failure of AFib. Above 130, the hazard ratio, odds ratio goes even further up. So that was another interesting thing is, well, how do we deal with these patients that have tremendously large left atrium? And then continuous time in AFib, obviously we know is a predictor. So this is a slide I put up, and we sort of start with this, and now we're down here. And whether it's evolution or de-evolution, I'm not sure, but we got to find some way of putting it all together. And I think as we learn more and more about AFib and its substrate and the modifying factors and so forth, and we learn from each other, and we can see what works. But now we're down to here, and we'll see where we go from there. So these were our points that we set off to address. Patients presenting with other arrhythmias, recurrence of their FIT from prior ablations, cafes, rotors, how do we deal with the appendage and its associated structures, how do we avoid mitral arrhythmias, and what do we do with the posterior wall, and how do we deal with that? Because we know from similar to the, if you don't isolate your posterior box, it's not complete, you can get these recurrences from within the box. So then we decided to do our transcatheter prior to surgical approach. It starts off, as all of you, we do imaging prior. OSA workup, we mandate prior. Now, treatment thereafter is difficult with these patients, but we know from the research, and literature that OSA is a clear predictor. If you have it and not treated for it, upwards of 20% predictive factor of failing in your AFib post-ablation. So we try to address that. In mittens, you just can't do it much when patients refuse to wear their masks. But we did do that. And then I always attempt one attempted sinus of rhythm prior with initiation of an antiarrhythmic pre-procedure if they're not already on one. My procedure starts with me. I do my own TEs on every patient. Fairly typical wide area with carina, depending if it's a common os or not. Touching it up with focal. Roof, we do extensive cafe and ablation myself, which I then hand off to the surgeons the next day, which we'll talk about. Any other rhythm clinically. Now, I'm sort of indifferent when I see induction of arrhythmias, when you're giving isopril or rapid pacing. I don't believe in necessarily chasing those arrhythmias. I believe unless it's clinically relevant, I'm not sure we should be ablating on these arrhythmias at the time because you then also can be adding substrate with incomplete lines for other arrhythmias. So our rule of thumb is we only go after clinical arrhythmias that they show prior to the procedure. I then go back to the right, perform a cava line, and then I adopted this where I go into the CS os and I sort of perform 3-4 ablations circumferentially around in that musculature idea and the recurrences that we've seen in the past. And then I implant a link or a Reveal XT. Reveal XT in the beginning, now we've moved to the link recorders. Day 2, the surgeons, fairly typical, they do their antral clamps and isolations. We pace and ablate ganglia. They do draw a box, but then this is, what we do a little bit differently is we fill the box in a stepwise fashion. So rather than worrying about if the box is isolated, we simply fill it. You're there. It's very easy in a stepwise to step up. We fill it. We don't do a mitral line. I feel like that causes too much recurrent arrhythmias. We have enough to deal with. Why create more issues for ourselves? And then the appendage, as I said, we definitively clip all of them. There's been 3 we couldn't get just for the diameter of the os, but we go in with the intention of clipping it, and I believe that's an electrophysiologic process and thromboembolic, and then they do a good job if we get all our ligament of Marshalls. At that point, we then sort of tailor to the patient. There were cafe regions that we thought endocardially were hot and I didn't get to as well. I then have them with the pen go touch it up, and then the clip goes on last. So this is our follow-up. We use Reveal and links. Everybody knows how they work. The links are great because they're wireless now. So we know within 24 hours or so if they're having recurrences. And that has some anticoagulation possible algorithms that could change that, which we could talk about. Some of them do have pacers, ICDs. The 4 that did not get so 4 people didn't get this because we were trying, in the US, we had to stage them out so it gets paid for, right? 3 months before, 3 months after. The 3 months after, patients simply didn't even want to come in within the blanking window. So then that's why we opted to start implanting them during the procedure so we guarantee it. But of the 7, we had, we like the Zio patches. I'm not sure if you guys use that here, but it's essentially an electrode that sticks. They say it lasts 14 days, it's about 10 days at best. And we do this every 3 months for the first 18 months. So going forward. So this is the endpoint we use, consistent with all the societies. This is a whole another discussion, is AFib burden. This could be an endpoint in the future, particularly now with these recording devices we have in people. If you have it in 3 months prior, we can get a baseline and then figure out how well you've decreased it. Quality of life is significant, and it's hard to get that into an endpoint. But, if you turn a long-standing persistent into a PAF who has 2-3 episodes a year, gets cardioverted and still off meds, that patient will hug and kiss you every time they see you and call that a success. So we stick to these endpoints. I understand it because it helps us compare our registries and our trials together. But this could be something that, and there's rumors of at least HRS trying to adopt some sense of this into it. We're continuously monitoring until the batteries die on the monitors. And this is just my own little soapbox here, but I feel like we're weighing our results against people who aren't using continuous recorders, right? That's the problem. So, whether it's a 30-day or, and I'll show you one of our occurrences, how it happened. You're still missing it. No matter what, you're still missing it unless you have a continuous monitoring. I feel like there's asymptomatic episodes, which we know from the Discern trial. So, we don't like to stick our heads in the sand. I believe we're looking at this as accurately as we can. Discern show that, it really comes down to the point that the biggest prognostic indicator for having an asymptomatic episode is the ablation itself. So I feel like the patient's symptoms, you can't rely on it. You can't rely on these event recorders. Unless you're having something in there continuously, you're not going to truly see the recurrence rates. So this is what we have. This is we have a large database. These 32, every patient receives the same lesion set, all persistent, long-standing persistent. It's a standardized approach for these 32. Majority males expected, age 61. They're all overweight as expected and on par with the rest of the U.S. Persistence, 75, 25, so essentially 26 and 6. AFib duration, I think, is substantial. This is a hard population. I'd like to point you to this. 134 was our average CC. So these are not easy patients. We're punishing ourselves to take on this population. The comorbidities, as expected. This was, so this should be newly diagnosed OSA. And we have to figure out a way for the manuscript to pair this out of who's actually new and old diagnosis. And prior failures was 34%. Antiarrhythmics, they've tried multiple. Endpoint was isolation of the veins and any treatment thereof of other arrhythmias that we saw clinically that we went into ATTEND at the combination of the two. So we were able to achieve that 100% of the time. The clip, we missed 3, as I told you, and purely for anatomic reasons, not intentionally. We've never had it open to a conversion, touch wood, and no interprocedural complications. We've had 2. One was a pericardial effusion greater than 30 days out. I think that we always leave the window, as you saw, possibly that tacked up to the lung and sealed it. She presented about 36 days later, maybe beginning signs of tamponade. She was truly hemodynamically stable. We drained it as a complication, and we had 1 pleural effusion we had to drain. We discontinued less than 3 months. Some of that was unintentional, patients non-compliant, but the goal was 3 months. But we actually got under that because patients indeed stopped prior. Within the blanking window, we know accurately because we have the rhythm. We had about 13% of people had sustained atrial arrhythmias, whether it's fib or AT, within that blanking window. Follow-up, we had 19 between 1 and 2 year. Currently, we have 13. We just moved, actually. I think it's 18, 14 now. It was the last month. Greater than 2 year follow-up. Like I said, we missed 4, so we're at 88%. But I think with the Zio patch, we're doing a good job. But with the disclosure, I still think unless you have a continuous monitor, you're never going to know. So this is what we have right now. We have 87.5%. If you include all patients up to 2 years, we were 90.6 at a year. We lost 3 in the first year, and another one right around 380 days. And the irony is, you'll see here, all the failures fall within this 320 and 380 day frame. We have to still continue and follow these out. The majority were longstanding as suspected. 3 of the 4 were longstanding persistence, and 1 was a persistent. Looking at the failures more closely, what do we have here? So nothing obviously was statistically significant because it's too small, right? The good part about being a good procedure is we don't have a lot of failures to compare to, but we need a larger sample size. But what you can see is there's some trends happening, and we know this in literature. It's positive or negative either way with sustained arrhythmias during blanking window. What I see is these, 75% of the 4, 3 of the 4 had a lot of arrhythmias within that blanking window, and they did quiet down for about 10, 11 months, and then they had a recurrence. But I think this will trend as we enroll more. More MR, the one severe was offered open and he refused. He did not want the valve touched, so we were forced to deal with it the way we had to. Duration of AFib was much longer, antiarrhythmics prior. So all in all, look at this, the volume size of these 4 people were horrendous compared to, they're both bad, but this is much worse. So it's sort of predictable, I think, that these patients would have had a tendency towards failure if you look at some of these clinical predictors. Looking at it more specifically, I hate putting this because I feel like a lot of people, like in studies, falsely put this, but it's the truth. And I'll show you why. They're all in sinus rhythm right now. And so what do we have to do to get the 4 there? Well, the first gentleman, he presented with an AT. I brought him back to the lab, had to start it. Cardioverted on 1, started antiarrhythmic. He had an AT on his septum. We ablated, and he's in sinus rhythm now, off antiarrhythmic. This was the same exact patient, another septal. I was talking to someone out there. The 2 of these ATs were these septal ATs that I was able to get from the left side. This lady had AFib, but she also had hyperthyroidism with a nodule that had to be removed. She's interesting because her recurrences were 2 minutes while she slept at night, and she's untreated OSA. Would never have known that that was a recurrence if we had an event on, and it fell out of that 3-month window where you may even have a 48-hour monitor on, but the link caught it. So it's a failure. But she, to this day, has had 2 little episodes that she knows nothing, we had to do nothing about. And same with this gentleman who has his AT. They were self-terminating, so we didn't have to do anything for it. So really 2 of the 4 we had to actively bring back to the lab and ablate. But all 4 had sinus rhythm, and I think it's not too bad for this point. So procedure times we're still quantitating right now. Combined I think we're at like 360 something, 370 something, but we're having to square that away. But both of our times have come down, and Al can speak to this, but they still clamp 6 times per vein. But at times, they see drops much faster, so on clamp 2, 3 rather than 5, 6 sometimes. We're doing less GP mapping. I'm likely hitting some endovascularly. Now the wall, they still make the box, but filling it in at times is a lot easier than going back and checking it, redoing a line where you think there's a gap. And then there's no mitral issues to deal with. Endocardially, my flow times are down. My procedural times are down about 20 minutes. So not that significant. I don't do this for that reason, that I think you get too many nonspecific atrial arrhythmias that come about. I do it if I go in a persistent and things just look different. The veins are quiet, and then I will go up with the isopro to try to get some activity that I can trace, but it's not routine. Benefits, we have a high success rate. It is tailored to the patient because we're mapping them first, and we're seeing where cafes are, we're seeing where their clinical arrhythmias are, and then we translate it to the lab. This will prove, I think, with our numbers. The big thing is the adaptability and the logistics of it, because we're talking about doing it on the same day, but there's a lot of downtime for both docs if you're working on the same day. And the way we do it now, we started with no hybrid OR. So this is a way that can be adopted by any hospital. You just need an EP lab and an OR. The EP works first. It takes about 3 hours of my day. I then have the rest of my day open. I can do procedures. My surgeon's not held up that day. The second day, he does his procedure, not holding me up. And it's a good flow. The downside is anesthesia times twice, within 24 hours. But we keep going back and forth, and now we have hybrid OR, and we're gonna start doing it the same day. But it's sort of, we'll have to see what happens, because I think it's just more efficient this way. It's more adaptable for other hospitals to do. I think it engages electrophysiologists a little more to work with you as surgeons, because by them going first and you entice them with a pure heart, interesting arrhythmia is the map that they can find and map, and then with your assistance epicardially, if they need to find these further, we have that available. But I think the engagement is there, and it might help it out. Future questions, sequencing we're still working out. What is the optimal lesion set? We don't know. I mean, we're going to have to, we do a lot, as you saw, between filling the box, the CS. Eventually, when we get more patients, we're going to have to drop one out and try to randomize and see what its effects would be. I just think this ICM, they're interesting because we may adopt some pill-in-the-pocket anticoagulation. We know wirelessly if you're going to have an episode of AFib. So say you have a CHADS 1, 2, and they're maintained sinus rhythm on their continuous for 3-6 months. You theoretically, I'm not saying it, but it's possible you could take them off guidelines, despite what guidelines say. If you see within 24 hours they have an episode of AFib, they take a NOAC, within a couple hours they're anticoagulated. I'm not saying that at all, but there's rumors of this, and this whole pill-in-the-pocket anticoagulation, who knows what that could, I'm not saying I promote it, but it's just an interesting thought. And then obviously contact catheters, we're going to have to see what that contributes. So, thank you.
Thank you. Are there any questions? Harry?
Thanks very much for a nice overview, and well, for us first, impressions from this reversed order hybrid approach. And as you explained, it's quite convenient to do parts just to up to a certain level, so you know what you did, and then you know exactly, the surgeon knows exactly where to go from there. And well, the results look extremely good, and as you expand, we'll learn more from that. My question is on what's your, and especially what's the surgeon's impression on the matureness of the lesions you made. It's usually one day before, right?
Right, exactly.
And so is there an advantage to do it in this way? Because if you do it one at a time, or in one procedure, I mean, then you may get stuck sometimes with a lot of edema.
That's what I think. I mean, yesterday I was sort of alluding to it when I, thought maybe in Traiman you can work with, but I think electroanatomic maps, voltage maps, edema can cause low voltages. So I think a lot of this stuff we tend to rely on to look for gaps, because some people, per an endovascular standpoint for the non-EPs out there, after we do an ablation, sometimes people will do voltage mats or an activation to look for these gaps, and that would be unreliable, I think. I think within a day also, Topera, is a US, I don't know who's using Topera here, but the idea is a lot of this stuff could be moving targets, okay? So cafes or rotors could be moving targets. So I think if you will map them endocardially, I think it should, and you intend to ablate both endo and epi, it should probably be within a tight window if you believe they are moving targets, which I think they likely are, but,
yeah.
So.
And the link, isn't that sort of, well, one point is obviously what you report is that there's extremely few arrhythmias in the post blanking period on the link, and that really amazes me, because we as we are here in the room, we have a lot of atrial arrhythmias. I can tell you, even without needing an ablation or knowing that you do have atrial arrhythmia. So. It's probably also how you program the links. How do you do
so I was telling Ralph, we program to the most sensitive. I turn all ATAF on, and then it's troublesome actually, because we get a ton of false positives. And then adjudication, both myself and my EP, fellow EP, and nurse practitioner, all three of us have to sift through this. So it's a bit of it's a lot of work, yeah. But we leave it all on for this exact reason.
And obstructive sleep apnea, that's in your workup. I like that very much. Is
yeah,
that done with a questionnaire, or is there a consultation from a pulmonologist?
So all these patients come through me. So just start off the bat, I talk to them. There's enough of a waiting list that they can see our pulmonologist. They get the home study, plus minus further study if they need it for diagnostic purposes. I think it's another modification of AFib. It's a bit frustrating because these people they don't give you a fighting chance sometimes because they won't wear their mask. But I think it's clearly there, and that's sort of like a little sub-study sort of interest we have. Sorry.
Joe, really nice presentation, and certainly they're encouraging results. It would be interesting to see when you get larger numbers of patients whether they hold up. Just one comment right away, someone with severe MR really needs a mitral valve repair and a maze, and I think to offer them any ablation strategy, I don't care what the patient suggests or wants, they shouldn't be offered anything. If you're not willing to have your mitral valve addressed, then addressing the AFib is doomed to failure no matter what you do. So I would say, just as other things, we were talking, it can sometimes patients in AFib can have more MR than they really then the AFib can actually induce upgrade their MR, if you will. And we think it's really important in the evaluation of those patients to cardiovert those patients, reevaluate them with an echo, and then you can make a reasonable decision. But, in our work and others.
That's exactly what we did with him, and he felt so well for the 30 days he was in sinus rhythm. But if he still has
severe MR, he'll recur, and that's what I'm saying. If that MR is still 3 to 4 plus, then they need to have it repaired, because that's probably the mechanism, and that's actually a different type of AFib than lone AFib, and we don't know what the mechanism. There's almost no studies of the mechanism of what causes AFib in someone with a volume overloaded left atrium. It could be different. probably has some similarities, but I think until we know better, I think I'd be hesitant to do those with an ablation-only strategy. They almost always fail.
Yeah.
The other thing is I do agree with you. I mean, I'd share Harry's intrigue. We just did a big study with the Reveal, and there's so many arrhythmias in that first 3 months. I'm not sure how you, in this population with this huge atrium, how you avoided any arrhythmias. I've never seen anything like that.
Oh, it was 13. Yeah, it was
15 minutes.
It was 13.
You said none of them had any arrhythmias in the blanking.
Oh no, it was
phase.
12.5%.
Still very low.
Yeah, it's still low, but yeah, they
pretty-
did.
Pretty
I thought it was
remarkable.
too much for us, but yeah.
Well, no, that's less than any series I've ever seen. I mean, especially with epicardial surgical ablation, it's very, very common. So I'm intrigued. I'm not sure how to explain that. But I would say that how you presented still doesn't follow the guidelines. And I would urge you to present single procedure success rate, because once you had the touch-up ablation, then they should stay a permanent failure. If that ablation is after 3 months, then your single procedure failed.
Right, they're all
So your
included.
touch, but that's not 100% sinus rhythm. I
Right,
think
I
you
just
have to
put-
be very careful with that, because we do want to compare it.
Yeah.
The question is, this strategy, if it requires a lot of repeat procedures, then maybe it's not as helpful. I think you'd have to say that, and I assume you did not see any type of atrial flutter or atrial tachycardia in this small group of patients?
Post the
Yeah.
recurrences. Three of the recurrences appear. Two of them we brought back to the lab, and they were the septal ATs.
Yeah.
One was fib that she had, the woman with the 2 episodes of self-terminating at night. The other was a self-terminating. It appeared like an organized atrial arrhythmia on the 12 lead, but he terminated on his own and doesn't want any intervention. So I don't have internal electrograms to prove it, but he two of them were the septals, and that's an area that the surgeons and I talk about may possibly addressing a little bit better is the septal location.
No, they're excellent results. It'll be interesting to see as your experience grows. Thank you.
Thank you. Can I ask you one more question, just for the discussion maybe? You present your results in persistent and long-standing persistent AF patients, and this is a very interesting topic, this clinical stage, and we discussed it also last year. For me, it still is very arbitrary, because the long-standing persistent, actually, it's a rate control group, and you turn it into a rhythm control group, so you should probably call them all persistent or chronic. And probably also a question to Professor Kreins, how to deal with this in all the publications. If we treat patients with persistent AF, how should we report them and look at them? Should we look at the duration of AF as a marker of the substrate, or should we look at the clinical stage?
So I think it's funny. I have this whole belief where, it affects more of the studies and how we do our endpoints and how we select our patients. But I think there should almost be another group and we were on this conversation last night, where I think there's paroxysmal, then there's paroxysmal. And there's the paroxysmal who's in the late 20s, early 30s, no structural heart disease, had 1 episode a year, self-terminates, doesn't need antiarrhythmic therapy. And then there's the paroxysmal who's failed 5 antiarrhythmics, happens to self-terminate with a specified amount of time that we deem, and is 68 years old with a large left atrium and mild to moderate MR. That, I almost feel like, should be like an early persistent, and there's different evolutions. And I think that's what the Utah group with the fibrotic scaling system, these biomarkers we're trying to figure out. You stick catheters in these hearts, and somebody who's a long-standing and a persistent, you look in, there's healthy signal, right? And then sometimes you do a paroxysmal patient, and these signals are low amplitude, and you're looking around like, this patient looks like a persistent, and the persistent looks like a PAF. There's not a lot of fibrotic changes, and you sort of, so I agree, these labels that we give people, once you don't know, I tell patients, I said, I'll learn more about you when I can get inside and take a look under the hood, but.
Okay, that's a very late question, a very short,
late question,
please.
very
Yeah.
short.
And short answer, please.
I very doubt the burden for the patients putting them into 2 procedures. Can you explain me the advantage of putting such a high burden for the patient, putting them in 2 procedures?
So they do really well. So it's just I'd offer you the other side. So when we did it the other way, did thoracoscopic first, they come down a lot more beat up with chest tubes in, not feeling well. They're usually extubated that day of the procedure or so forth, but they're definitely more uncomfortable. They're not up and walking around. We do it this way, 3-4 hours, they're up walking around, they feel great, and they're almost psychologically more motivated to like move on to the second phase. We felt when we did the epi first, these patients sort of lingered more, they didn't recover as quickly.
Okay, if you, yeah.
Just if you have 50% success in the thoracoscopic procedure, for example, and you put your second phase 3 months later, then you have 50% of patients not having a second procedure.
You know, the problem with that is patients don't want to come back. And I say that and I cringe because I know that one of the sponsors is you know, we're going to be involved in that trial. But I think patients won't come back if they're in sinus rhythm. I think if you're in sinus rhythm for the first 3 months and you come back 91 days later, who's going to, I wouldn't submit myself to a transeptal and an EP study. You know, we tell patients this is a larger index procedure up front. You're going to minimize your repeat procedures thereafter, and that's what we're seeing. But you know, we sort of designed it for this reason, where patients weren't coming back, and I think it's an issue. But when you do the endovascular first, they're up walking around, they're ventilating their lungs. They could probably go home that evening, and so we haven't had an issue to date, actually.
Okay, thank you, Dr. Tiano.